I'm glad to be invited to come and talk. No pressure of being the first speaker of the 2020, so we'll see how this goes. So I've been asked to come and talk a little bit about neuromodulation. It's a therapy that's been around for a long time, but we find that a lot of people don't even know we exist, don't know who we are or what we do. So it's always nice to be able to share some of our work with you guys, and it might come in applicable for you guys as well. So I'm not just another tool. Hopefully I'm just another tool or two in the chronic pain toolbox. So just kind of the three things I'm going to go through today. I'm going to define neuromodulation, talk a little bit about the history of the field and of our clinic, talk about the three different modalities of treatment that we do and the uses for each, and then just briefly discuss some of the research supporting neuromodulation as a therapy and how we know that it's effective and useful and cost effective and whatnot. So in a nutshell, what is neuromodulation? Well, we're a surgical therapy that uses implanted devices to alter or modulate the way that nerve impulses travel throughout the body. So we all have nerve impulses flying all over our nervous system. Some of them are doing what they're supposed to do. Some of them are causing some abhorrent effects, and we want to find a way to try to block some of those. So the main uses from our point of view are chronic pain, spasticity, and then different types of movement disorders. There's two ways that our systems can function, either electrically, so using electricity to suppress these signals, or pharmacologically using medication. We can function either centrally, right on the brain or the spinal cord, or peripherally out wherever the therapy is needed. And like I mentioned, it's not a new therapy. It's been around for a long time. And we can actually go way back to 46 AD if you want to find the first historical documentation of something neuromodulation. This is way times, and there was this and he used a fish called a torpedo fish. So it looks like this. It lives in the Mediterranean, kind of swims around on the bottom. It's about as big around as a dinner plate, and it's a lot like electric eel. So it has a defense mechanism where if it's threatened, it can produce up to 200 volts of electricity to discourage predators. So what this Dr. Largus would do, he would take these fish and use direct contact onto the patient that was having pain. Say they were having pain on their back, he would take one of these fish and slap it on the person. The fish would kind of freak out, do its electrical thing, and he found that it would decrease the pain a little bit. Or for someone that had, say, something like gout, where they had pain in their feet, he would have a tank of a couple of these fish swimming around, put your feet down in there, again, the fish would do its thing, and it was actually decreasing pain. I don't think he really knew what he was doing, but he felt like he was numbing the nervous system somehow, and it worked. So over the years, other people picked up on this whole idea of using electricity to treat pain. Here you've got Ben Franklin and some really creepy looking lab assistants there. But he was the one, of course, that kind of discovered electricity and came up with ways to harness and store it. And he was kind of the next person along the line that started using this and applying it to the body in different ways. When you get into the 1800s, you have this guy, Guillaume Duchesne in France, and he used electricity to explore and map nerves and muscles throughout the body. I don't know if this is something anybody wants to volunteer for, but he was using electricity on these little skin hooks to kind of map the way that electricity was affecting the nerves and the muscles throughout different parts of the body. And some of what he was doing is actually still used today in the cosmetic industry. It's called sporadic therapy. I don't know that any of the people on this slide are going to be good advertisements for the cosmetic industry, but this is some of the work that he was doing, and he would map the different nerve impulses and reactions he was getting from electricity. And he actually published some speculations about using electricity to cure death, which may be where this guy came from, maybe one of the earliest neuromodulation patients. Who knows? This didn't really catch on, though, for some reason. When you get into the modern times, you get Norman Shealy in the 1960s. And he was the first person that really talked about using electricity directly on the spinal cord to control pain. So he developed what he called a dorsal column stimulator. He built his own electrodes and power supplies, and he was implanting them right into the CSF, right up against the spinal cord, and stimulating directly the dorsal column. And he got a lot of success. He was getting pain relief, but because these devices were basically homemade, they weren't really designed for this, so they were quite bulky. He had a lot of issues with spinal cord compression, CSF leak, infections, and all that kind of stuff. So his side effects were kind of outweighing the benefits he was getting at that time, but he was definitely on to something and had some significant success. So that's where Medtronic kind of came along. They, of course, had built their business on cardiac pacers, and they decided that they could re-engineer their cardiac pacers to be more adaptable for this type of therapy. So they started using their cardiac pacer leads and their pacemaker batteries, and now they had something that could be implanted very easily and effectively into the body, and now in the epidural space, and using implanted batteries to do the same thing that Norman Shealy was doing without all the side effects and the harmful effects. And this is kind of where things started to develop into Canada. Neuromodulation at this time coined the term of neuromodulation. They brought the stimulators, the deep brain implants, the drug systems all together under this umbrella. And this all caught the attention of Dr. Kumar. If any of you remember Dr. Kumar, who was here for many, many years, he kind of had two passions. One was people that were in pain, and one was technology and being on the cutting edge. So when this technology was developed in the States, he kind of jumped all over it and wanted to be part of it. He was the kind of guy that always had to have the latest and greatest technology. He couldn't always use it, like the latest iPhones and whatnot, but he always had to have it. So he was very excited to get on this bandwagon, and because of that, he embraced this therapy, and he really became world-renowned and kind of put Regina on the map for this therapy. So because of his work, we now have centers all across Canada that are doing these type of therapies and helping their patients tremendously. We were quite fortunate that he was here for all his career. In terms of our clinic here, so we're an outpatient clinic. If anybody doesn't know where we're located, our physical location is up on 5A here at the General. Our population has grown to over 550 patients. If you think about these devices, once they're implanted, they're not a curative device. So once people have these devices, they have them forever. So they need to be maintained. So that means our patient population just goes up and up and up. We currently only have one surgeon doing the implanting right now. That's Dr. Buembo. We have 2 nurses and we have a pharmacist. And our main goals are patient care, of course, education, and then we still do quite a bit of research. So that's kind of the history and the definition of neuromodulation. I'll talk a little bit now about the 3 types of therapies that we use and the uses for each one. So the main 3 therapies are the spinal cord or the peripheral nerve stimulation. That's the biggest one we do. The intrathecal drug pumps is kind of the second one. And then we also do deep brain stimulation. And in terms of centers across Canada, our center and Saskatoon are the only 2 centers across the country that do all 3 modalities. Most other centers will focus on deep brain or focus on spinal cord stimulations, but very few will do all 3 therapies. So spinal cord stimulation is the biggest one. It accounts for about 70 to 75% of all of the cases we do here. And these numbers might be a little bit old now, but it was estimated a couple of years ago that about 40,000 SCS systems a year are implanted worldwide. So it's a big, big therapy. Basically, what we're doing is the same thing that Norman Shealy was trying to do, using electrical impulses to stimulate the back of the spinal cord and block those pain signals. So you think of someone with pain, they've got pain coming up, say, from their foot up through the leg. Those nerves join onto the spinal cord, and the transmissions go up to the brain. So we're just using a little bit of electricity to block those pain signals that are coming up. Whatever the main issue is, we haven't found a way to correct it or fix it or cure it. We're finding a way to suppress and block those pain signals. So we can either enact directly on the spinal cord or out in the periphery. And basically what we're using paresthesia, so a light tingling sensation of pins and needles to overlap wherever their areas of pain is. And generally, if we can overlap those area of pains with paresthesia, we can block a good chunk of those pain signals. The whole theory behind this was based on what used to be called the gate control theory, which kind of said that there were gates and blocks all throughout the nervous system. And if you could figure out a way to open and close certain gates and block certain signals, that's kind of what we're trying to do here. The nice thing about spinal cord stimulators is that patients have a lot of control over their device. So they can turn them on and off, they can adjust the stimulation up and down. So that means they don't need to see us quite so often because there's a lot of things they can do to troubleshoot on their own. These devices last quite a bit longer than some of the other therapies they do in terms of battery life of those devices. And most people find that the paresthesia, they describe it as a soothing sensation, almost like an internal massage, which kind of distracts and blocks those pain signals. We tell people right up front that we can't make them pain-free. We haven't found a way to make anybody pain-free yet, but we shoot for a pain reduction of at least 50% or more. That's what we would call a success. The primary uses for our stimulator systems are failed back surgery syndrome, So someone that's had a lot of back surgeries, their spine is fixed and as stable as it can be, but for some reason the pain signals didn't go away. And that's what we're trying to find a way to correct. The other main use we do is complex regional pain syndrome. If anybody's heard of that, it's a terrible, terrible pain disorder, but stimulators seem to be quite effective for treating that. There's a lot of secondary uses as well, like angina, craniofacial neuralgia, some types of migraines, post-surgical, like post-herpetic, ilioinguinal type of pain. So if we can kind of find the nerves that are causing the problems and we can get an electrode to that spot, we can generally block the pain, or some of it. This is kind of what an SCS system generally looks like. It consists of electrode, a battery, and then there's a couple of peripheral devices. So a patient controller, so they can make the adjustments, and then some of the batteries will have an external charger as well to keep that battery charged up and running for as long as it can. There's lots and lots of options and configurations, from skinny electrodes that can be put in percutaneously with a needle to some of the bigger paddle electrodes that have to be done in the surgery with a laminectomy to get them into the epidural space. So there's lots and lots of options. There's 3 different companies that make these devices. So we can kind of tailor which device we think is going to work best for which patient and which one they're going to be able to use the easiest. With all of our process, we do them in 2 steps. So we always do a trial and then an internalization. Even though our success rate for these devices is about 70%, it doesn't work for everybody. And before we go ahead and put this whole device inside the body, we would want to make sure they're going to get some benefit from it. So we'll do a trial procedure first of all, where we'll put the electrode in and have an external battery, and the patient gets about a week or 2 to try it out. We'll teach them how to use it, help them adjust it, and see if they're going to get any benefit from it before we go ahead to commit and put the whole device in. If everything is successful after that week, then we'll do a second procedure where the electrode is already in place. We'll put the battery in, hook everything together, and then it's fully implanted at that point. Or if it doesn't work or they don't like it for some reason, that second procedure is to take the electrode out. This is all reversible. Everything can come out pretty much as easy as it can go in. So there's nothing that is necessarily permanent in the body. We do get a few people that decide they don't like the system for one reason or another, whether they don't give it a full chance or whether they don't like the stimulation or a few different things like that, but most of the people get a significant benefit from it. Depending on what type of pain we're treating is going to determine where we're going to put the electrode. So you can see from these images, there's lots of different placements. It's kind of like real estate, location, location, location. So if it's in the spine, that one on the upper left there, that shows one of the paddle electrodes in the thoracic region, probably for back and leg pain. The one on the right, you can see the 2 electrodes crossing. That would be on the back of the head for someone with a migraine type disorder. As I said, our goal for a successful trial is a minimum of 50% pain reduction. If someone comes to us at the end of the trial and says, I'm only getting about 20, 30% relief, they might think that's great right then, but we find that a month down the road, they're just not happy with that, and they end up asking for everything to be removed. So we try to hold hard and fast to that 50% pain reduction, but most people get that. These are expensive systems. They can cost up to 40 grand or more, not counting all the surgical and hospital costs. So it is a pretty pricey thing right off the bat. And a lot of the research that was done when Dr. Kumar was alive was proving that these devices are cost effective in spite of that heavy upfront cost. And I'll talk a little bit more about that towards the end. So those are the stimulators. So out of our 550 some, we probably have 350 to 400 of our patients that are stimulators. So that's a really big chunk of our population. The second biggest one is the intrathecal drug delivery systems. So some people have heard about the morphine pumps or the baclofen pumps. So now we're not using electricity anymore, we're using medication to control the symptoms. And the main benefit to this is allowing a bit more targeted drug delivery with less side effects. So instead of them having to take narcotics that are systemic, we can target it a bit more and make things a little bit more effective. Main uses for this is different types of neuropathies, and really specifically someone that has almost all low back pain. Stimulators work really well for leg pain and kind of up to about the bum or belt line, but anything that kind of gets up into that low back pain is tough to treat with a stimulator. So for those people, we'll generally default to a pump for those patients. Also spasticity, so people with MS, CP, head or spinal cord injuries sometimes get really contracted and have a lot of spasms. You can use baclofen in the pump to help loosen that up and make it easier for them to mobilize, position, those kind of things. A lot of pain patients also have spasticity associated with their pain, so we can also mix a little bit of baclofen in with a narcotic in the pump, for example, to give them some benefits that way. So because we're not using a systemic medication, something that doesn't have to go through the stomach and the blood and all those barriers, we're skipping all of those. We can get a much lower dose. We generally get a lot less side effects, so that whole fuzzy-headed narcotic feeling is less, constipation is less, tolerance is a bit less. So that's the real benefit. Someone who's using medication and gets benefit but has a lot of side effects is generally the perfect patient for a pump. Just as a comparison, when you're looking at morphine, if you're looking at 30 milligrams of oral morphine, if you convert that to a pump dose, you're down to about 0.01 milligrams. So it's a huge difference in dosing. There's 3 different narcotics that we can use in the pump. We'll always start with morphine. If we need to, we can move to Dilaudid, and fentanyl would be the 3rd step. I mentioned baclofen can be used. We have a few patients that have clonidine in the mix as well. Clonidine in this application tends to almost act as a booster for whatever else is in the pump. So if you have someone who's getting, moderate pain relief, but maybe you've kind of plateaued, adding a little bit of clonidine can almost kind of help to potentiate those effects a little bit. Some people that have different types of neuropathies with that really burning pain, we can use bupivacaine in the pump to kind of numb those symptoms a bit. And there's a couple of really good options that are being used in the States. The Conotide in particular has now become first line above even morphine or the narcotics for pain control in the pumps, but we can't get the company to import Conotide into Canada for some reason. Monica has fought tremendously to try to get that to happen, and she's not been successful yet. One of the big differences with the pumps is that patients have no control over this. So we don't want them to be able to, play Jeopardy and give themselves a whole bunch of doses. We're the only ones that can set that dose. They obviously have to come in for refills, and the interval between refills depends a little bit on the medication being used and the dose. In most cases, it's between 3 and 6 months between refills, so they can go quite a while without having to come back and see us. There are complications, of course, like with anything. The pump itself is pretty bulletproof. We don't see very many complications with the pump, but the catheter, because it's quite flexible, can kink or block or break over time. And there's another phenomenon called a granuloma, where in some rare cases with higher concentrations, we can see a growth of tissue that starts to form around the tip of that catheter. And if it grows to a size where it starts to cause spinal cord compression, it can be an issue, of course. So in those situations, surgery would be required to correct that. But we generally only see that in higher doses narcotics, and it's still pretty rare even at that. A lot of people, if you look at the forums online, people talking about pumps, they're always worried about overdosing. Really, it's underdosing that is the main concern. If the catheter blocks or the pump quips, they're going to go into withdrawal. Really, the only way for an overdose to happen is if I make a mistake. If I enter the wrong number onto the tablet or miss a decimal place or something like that, and it's delivering more than it should, there's no situation where the pump is all of a sudden going to spew its medication out or over-infuse or those kind of things. But those are kind of the perceptions that some people have out there. We do these procedures as trials as well, so we'll put the catheter in. We have an external pump, and again, they get about 2 weeks to try it out and see if it's going to work before we commit to it. The pump is quite large. It's about the size of a hockey puck, so it's definitely a bigger device than the batteries are for the stimulators, and it generally gets implanted just in the belly under the skin there. That port right in the middle of the pump that you can see, that's what we use to do our refills. So when patients come in to see us in the clinic upstairs, we're just using a needle through the skin into that port, empty out the old medication, fill it up with the new stuff, and away they go. Just some images to show the implants in place. On the right there, you can see the pump and the catheter coming around from the front. On the left, I don't know how well you can see that. It's a very thin line along the left side of the spinal column. And if you follow that up, there's a little black dot at the top. That's actually the catheter, and there's a radiopaque marker on the tip that allows us to be able to see that quite easily on X-ray to confirm our placement. The whole pump needs to be replaced every 7 years. The catheter only needs to be changed if there's an issue. And these are by far the highest workload for us, because we have to do all the adjustments for the pump, so titration is done by us, refills. So these patients tend to come into the clinic on a higher rate than the stimulator patients do. These numbers are also a couple of years old, but these came from the States, I believe, that was quoting medical management of someone in chronic pain costing about $46,000 per person per year. And some research done was showing that pumps for the same type of patients are costing $16,000 per person per year. So there is a definite cost benefit with the pumps. So that's number two. So the third treatment that we do, so now we're a little bit off track of pain now. Deep brain stimulators are used mostly for movement disorders. So here in Regina, we use them mostly for Parkinson's disease and essential tremors. And again, this is a therapy that can be traced a long ways back. You may have seen some reports recently in the news talking about using DBS for addictions or PTSD. There's some centers in the States that are starting to work with those, which I think are phenomenal applications if they can become viable. So these now, we're putting our electrodes deep within the brain. So you can see from this image, this is kind of the area that we're targeting. So that bigger image, you can see that tiny flat blue area in between the pink and the purple. That's the area that we're targeting for Parkinson's disease. So it's a very tiny area, about as big as the nail on your pinky. And that's the area that we need to get those electrodes in to try to stimulate to help Parkinson's disease. So the system is very similar to our spinal cord stimulators. We have the electrodes and we have the battery, and they have controllers on the outside that allow them to adjust it within reason as well. So this procedure we do all as one. Patient is awake for most of the procedure, and we do our trial during the intra-op procedure. And if everything works well, then we go straight to internalization and do it all at once. It's a big procedure. It takes a long time, and there's a lot of staff involved between neurophysiologists and our team, the OR team, and everything. The patients can get pretty uncomfortable as the day goes on, but the benefits are usually outweigh that. So I'll just kind of skip a little bit past the procedure. It doesn't apply too much, but there's a lot of pre-op planning that's done. We use MRIs to help us plan the trajectory so that we're missing ventricles and blood vessels. There's a big apparatus that gets attached to the patient's head that helps us guarantee that as we advance that probe, we're following that exact trajectory that we planned. And as we're passing through the brain, we actually do it twice. So on the first pass with the probe, we're using a computer that has a little microphone and actually listening to the sound of the cells firing, and that helps us to confirm our target area. Once we kind of confirm that sweet spot, we'll go back up to the top and we'll go through it again, and this time we'll stimulate to look for benefits and side effects. And the benefits, of course, we're looking for decrease or arrest of the tremors. For someone with Parkinson's, they get very rigid and bradykinesic, so we're looking for those kind of reliefs as well. Some of the side effects we can see that our target areas are very close to some areas in the brain that deal with speech and muscle contractions. So that's why we need the patient to be awake. So as we're talking to them, we can make sure we're not slurring their speech, getting pulling of the muscles in the face, paresthesia in the fingers, double vision, those kind of things. We need to be able to watch for that. And none of those effects are permanent. They're just there while we have the stimulation on. If we see those effects, then we know we need to move our probe a little bit, a millimeter one way, a millimeter another way, or up or down to try to decrease those side effects. So those are just some x-rays that kind of show the whole system once it's implanted. So this would be a bilateral case. So you can see the two electrodes going down deep into the target there. And then the electrodes from there will connect and run down the side of the neck and down to the battery. The battery generally gets placed just like a pacemaker would under the collarbone. So those are the first two topics. I'll kind of close just by talking a little bit about some of the research that we have. A lot of the research that Dr. Kumar did back in the day was working on proving that spinal cord stimulation in particular was both effective for pain management, but also was cost effective. So I mentioned all the upfront costs for these devices, and they are pretty pricey. But Dr. Kumar's research showed that when you compare someone with a spinal cord stimulator, even with that heavy upfront cost, to someone who's on medical management, it only takes about 2.5 years for those two streams of funding to actually meet, and then the stimulator becomes much more effective. Someone on medical management is going to have more ER visits, more medication costs, more treatments. That cost is going to go up, whereas the stimulator cost is going to go down over time. So it only takes about 2.5 years to recoup those costs. So some of his research was crucial for a lot of health regions around the world and across the country to prove to their funding agencies that these are something that they should fund for their patients. I tried to find a literature that looks specifically at opioid use and reduction with neuromodulation procedures, and there really isn't anything out there that specifically focuses on that. We did our own little project a couple of years ago and just followed 59 patients pre and post a spinal cord stim procedure. And we did found that of those patients, they were dropping their opioid use at 1 year by about 58%, which is a pretty significant use, and hopefully that would continue over time. We did kind of explore the idea of doing a bigger project to try to get some more data on that. It hasn't come together yet, but I think that would be something that would be quite valuable, especially in light of today's issues. So just as a wrap up, I certainly don't want to say that neuromodulation is kind of the be all and end all. It certainly isn't the wonder therapy that's going to fix pain. If it did, we wouldn't have opioid issues. We wouldn't have all these pain clinics and whatnot. You know, I think the best way to treat pain from my point of view is definitely a multidisciplinary kind of approach that includes us and pharmacology and PT and OT, psychiatry, psychology, all those different things. And I think that's something that Saskatchewan would definitely benefit from. And it was Dr. Kumar that actually used this quote that kind of named my talk today. And he used to say that neuromodulation is just one tool in the toolbox of chronic pain. And it takes all of the tools, all of us, to try to help treat these patients. So that's about it. I'm happy to take any questions or comments from anybody.
How do you determine the 50% reduction?
There's no real way to measure it. It's all patient reporting. So we generally use, you know, the VAS score, 0 to 10 kind of pain score. There are lots of different questionnaires that talk about pain and try to assign scores to them, but it's a really hard thing to measure. So it's all patient reporting, basically. And sometimes we'll have a patient that'll come in that say, you know, I don't really think this is helping to me, and their spouse or something next to them will turn and give them a whack and say, you know, you walked around the block with the dog, you'd never do that before, you're sleeping through the night. So sometimes they don't even see the benefits that some other people see.
What is the funding situation like in Saskatchewan? Is this something that everyone who's eligible can get, or is it a special case-by-case basis?
No, we've been lucky because of Dr. Kumar's history that there really hasn't been, at this point, any caps put on us. Fingers crossed that that doesn't change. Lots of other centers, they have budgets throughout the year, and they maybe can get half a dozen cases done a year. But we've been quite fortunate that pretty much anybody that gets approved or deemed to be a candidate by Dr. Buembo pretty much gets implanted, or at least gets a trial.
Great.
Yeah.